Hey, everybody, this is Dr. Michael Kay from the Center for Functional Health, and I'm so happy and honored to have with me today Dr. Paul Kosmorsky, and we're going to talk about bioidentical hormone replacement therapy. I've been looking forward to this because we have a lot more patients asking questions about hormone replacement therapy and trying to figure out, is this for them? Is this not for them? What's the difference between the bioidentical hormone replacement therapy and hormone replacement therapy, and why sometimes their docs don't even want to talk about hormones? So welcome, welcome. I'm so glad to have you come along and share your knowledge with us tonight.
Thank you very much for inviting me here tonight. I'm excited to talk about helping patients out.
Great. So before we begin, can you share with everybody your background? Like, how did you get to here? How did you get to be talking about and utilizing hormone replacement therapy in your practice?
Well, I am a doctor of osteopathy. My brothers are doctor of osteopathy as well. I went into primary care. Those two went into specialties. I had, went into general practice and very interested in personal care. About 1992, I guess that's 31 years ago. I enjoyed every bit of practice and worked very hard on every day and still do. Um, I developed protocols to help people with different problems. We've also started um, uh, how to get people from having problems with depression and anxiety, and what is the root cause of that. People come in and say, I have some problems, and they have depression problems or anxiety problems, or they have energy level problems. And giving just antidepressants or anti-anxiety medications never solved any problems. So we looked to the root cause of it. So looking at hormone therapy that someone introduced to me many years ago, I avoided it first because it's non-traditional,
Mhm.
and I was trained as a traditional physician. But I actually had problems dealing with patients on a regular basis that no one could solve their problems. If I referred them to endocrinologists, that if there's a thyroid problem or there was a insulin problem, still they came back to me and said, I just don't feel right. I'm taking these medicines, but I just don't feel right. I still don't feel right. And me being the general doctor, I'm supposed to say, well, you're going to be cured by anybody who's a specialist. They should help you. They should do everything possible to help you. But it never really worked. So they came back to me. So I had to develop answers. And I am generally someone who likes to find answers for people. So when someone introduced me to the BioT process, it's called BioT, the company is BioT, but it was bringing optimization of hormone levels for men and women. And a lot of people struggle with fatigue, depression, uh, women with menopausal symptoms, men with libido problems or concentration problems or sleeping problems, and they sought. I mean, low T became like a big buzzword
Mhm.
years ago. I want to take these hormones to get me better. I want to take these supplements to get me better. Whatever supplements, there were tons and tons of different supplements that people would take and still take now, uninformed, and still go on the internet. And it's a big market for people that want to take some energy boosting supplements. But when we were trained, we were taught that testosterone at the bioavailable and bioidentical, meaning molecularly identical testosterone, is beneficial not just for energy and libido, but it protects the heart or protects the body from cardiovascular disease. It protects the prostate from prostate cancer, and testosterone and estrogen in a good way for women as well protects from breast cancer and ovarian cancer. And we were lectured on this. I thought, this is crazy, but it sounds crazy, but it really does work. And one seminar I went in 2013, then I decided, being a very, very busy practitioner and getting into my 50s, saying, I'm tired too. So let me get treated. And within 10 days, a light went off in my body, and instantly I felt superior. I felt so good. I felt so alive and energized. And I haven't looked back since. So I started to initiate this protocol, BioT, for my patients, and we've become one of the largest distributors of bioidentical hormones in the Northeast Pennsylvania and the East Coast of the United States. So we make sure people feel better, and we make sure people understand the process that goes behind it, and we'll talk about that.
Gotcha. So you said, the light turned on. I can't tell you how many patients or female patients come in after they're getting progesterone. They say it feels like somebody turned the light on. I feel like just an energy surge. And then they realize like how much they were actually missing. I mean, one of the big things is brain fog, right? The walking into a room and forgetting why the hell they walked into the room. And it just went away, and everything just felt so much more acute, and their focus was better, their concentration was better. And then joint problems, like we'll see them for like this shoulder problem, and some of even the musculoskeletal pain also lessened by having hormone replacement therapy. And a lot of people I don't think talk about that. And having a background of osteopathy, you can really understand how the musculoskeletal is involved, and people don't think about it, and they get on the hormone and they're like, hey, that shoulder feels better, because there's this demographic of a lot of women moving into menopause, and they wake up one day and they say, I got the frozen shoulder, and there becomes a hormonal imbalance. We look at it from that hormonal perspective. They start taking the hormones, and it really helps that musculoskeletal.
And the hormonal imbalance causes inflammation. Inflammation causes the arthritic and osteoarthritic problems.
Correct. So, it's really interesting to see, because, when people think of hormones, they just think testosterone and estrogen. They don't realize that there is our whole body is run by these chemical messengers. So if we can touch base on, like, let's start with, the TSH, the thyroid stimulating hormone. Can you give us a brief background on TSH, and then how you guys look at TSH?
TSH is the hormone from the pituitary gland that says to the body, you don't have enough thyroid hormone in your body, whether it's from aging or lack of foods that help with developing thyroid in your body. So the TSH, thyroid stimulating hormone, increases when there's a decrease of thyroid in your body. So to replace that, doctors of medicine and traditional medicine developed a synthetic compound called Synthroid. It's basically T4, but T4, unfortunately, is not the active ingredient or active process for thyroid to be utilized in the body. It has to get converted to T3. So a lot of people can't convert Synthroid into the effective form to increase their thyroid. Now, we know that thyroid is a metabolism hormone. It regulates temperature. It regulates your heart rate. It gives you an energy process, allows you to sleep better. So if you're not getting the proper amount of thyroid in the body, then these things are also complicated, as well as hormone, as well as low estrogen or low testosterone. So I use I use a natural thyroid from pig's gland called Armour thyroid or nature thyroid. And that is basically T4 a little bit and mostly T3. So that when we measure T3 in the body, the higher the free T3 in the body, the more that the level of thyroid is normal.
Gotcha. So with patients that are on like levothyroxine, and some take then Synthroid of the same, and then Armour, do they notice a difference when they go from one pharmaceutical to like the natural pharmaceutical, if you can call it that?
Yeah, there's allowable 25 to 30% variable in medicines that are created that can be inactive. So, but with Armour thyroid, it's 100% active. So yes, I've gone from levothyroid, which is also it's Synthroid. It's also synthetic. It's just a generic form of Synthroid, which is synthetic. But I switched them to nature thyroid or to Armour thyroid and got much better responses to increase the amount of thyroid and decrease the TSH.
Gotcha. So, I learned that, TSH is the 0.45 to 4.5. and then some discussion now is like, hey, even if it's up to 8, 9, 10, we don't have to do anything about it. Is there a reference?
I like it. I like it 1.5 or below.
1.5 or below.
That's correct.
Gotcha.
That's my goal. If I get 2 or 3 and their free T3 is of sufficient level, then I'm okay, because I don't want to push it too much. Because sometimes you push thyroid too much, they might get jittery or nervous, or
Right.
the other way, decrease sleep because of irritability.
Gotcha.
But there's a fine line between TSH and free T3 with armor thyroid.
Gotcha. So when looking at these other hormones, do you also take into consideration like cortisol or HGH? Because HGH for a long time was really big, especially in the fitness world. Melatonin. Do you look at those type of hormones as well?
I don't specifically. What we do is we look at free T3 with testosterone, free testosterone, estradiol. We don't the DHEA, we look at that sometimes. Cortisol, we don't really focus on cortisol because that could be changed by stress or sleep disorders, and you can't get, that's a very variable number. It can change from 7 a.m. to 7 p.m. and it's too volatile for us to actually measure. So we just measure the thyroid, the free T3, testosterone level, estradiol level, and don't worry about melatonin levels or anything else.
Gotcha. And do you feel there's a concern? Because sometimes I'll run the testosterone level and I'll look at the sex hormone binding globulin, and if that's really elevated, then I'm concerned.
Yes, because sex hormone binding globulin is a protein that allows the testosterone to be distributed. If it's too high, that means there's not enough testosterone around, and then you have to adjust your levels. So yes, sex hormone binding globulin is very important as well.
So I assume like when they get a testosterone replacement therapy and things begin to even start to become even, then the sex hormone binding globulin will then
go down.
Go down. So
appropriately, and people will feel it. They'll feel better because of that.
Right. So in sticking with testosterone, progesterone, estrogen, can you share what an individual would experience if those are above the reference range or below the reference range?
Well, we know that we were taking patients basically from mid 20s and 30s all the way up to 80s. And a lot of men have decreased optimal levels of testosterone, and women do as well. So we watch the level of this testosterone very, very carefully. Let me re-ask you what your question was specifically about the testosterone.
So you just brought up another good point, was the testosterone. So I also see a lot of young men like in their 20s, and their testosterone is way low. I mean,
absolutely.
And I'm going to be 60, and my testosterone is out trumping their testosterone, right? And like this shouldn't be, but it is, right? Now it has to do with lifestyle and all the other stuff. But they changed the reference range on us. They did that a couple years ago too.
Well, this is a good thing to also tell. In the reference ranges that we use the traditional labs, LabCorp and Quest Labs.
Yeah.
So their reference levels are from 250 to 1,100. So traditional doctors don't get trained in testosterone level, and a lot of them avoid what's going on because they're not trained to know what an optimal level of testosterone is. So they'll see some testosterone in a 28-year-old that'll be 320. They'll say, "Oh, you're fine," and the patient will say, "But I'm tired and I feel depressed and I'm just not able to do the things I'm supposed to do." Well, we'll give you an antidepressant. Don't worry about it. And they completely ignore the fact that the testosterone is a suboptimal level.
All right. So aside from the low energy, in men and women with low testosterone, what do you see your female patients experience with low testosterone and your male patient experience with low testosterone?
Female patients feel low energy, decreased sleep, irritability. Men too, sleep problems, decreased libido, lack of concentration skills, and lack of ability to exercise on a regular basis as they had been 5 years earlier. Women as well, libido. Women have difficulty with libido as well with the low testosterone. So when we optimize that, we really cure a lot of problems, not just libido problems, but work a day, every day working, every day dealing with the stresses of life.
I remember like all these low T clinics started popping up everywhere, and really marketing it from their perspective of erectile dysfunction, ED. But we also see like, okay, you have low testosterone, that may not be directly correlated to the erectile dysfunction, where it's more of a blood flow issue.
Oh, absolutely. Sometimes,
So,
correct. Sometimes, well, when men come in specifically and say, I would like testosterone, they might hide their reasons why they're not just decreased libido. They might have erectile dysfunction. We're going to tell them, we're not going to directly cure your erectile dysfunction with testosterone. We'll increase your libido, we'll increase your energy, your sleep problems, and everything else. But we do send them out for ultrasounds. We send them to urologists, and if there's a blood flow problem to the area, then that's a different problem.
right. Now, I had a patient, male patient, whose testosterone was low, uncomfortably low, and then it turned out his prolactin was really high, and then they found, a pituitary like tumor, and that was causing the issue. So, we look at it from that perspective of if that testosterone is low, we also have to look at other things that could be contributing to that.
Well, and then this is the difference between testosterone centers and our center. Our center is based on physicians and nurse practitioners that actually do general internal medicine, general practice,
Right.
as well as testosterone replacement. So when we do a panel that we know the whole body, and we have a very comprehensive history and physical for the patients, and a very comprehensive lab evaluation of the patients. So we'll find different things. We might even find that this patient can't get this treatment because, lo and behold, we wind up with an X-ray, or we wind up with the fact that this person might have stress issues or cardiovascular issues that we have to refer them before they can even do this therapy. So we make sure that everyone is screened before they get testosterone or estrogen.
And that's one reason I wanted to talk with you tonight. So glad you came on, is to share with everybody, like, hey, just running to our local low T clinic is not the answer. I think there's so much more that we have to really dive
Oh,
deep
absolutely. We're a comprehensive center and medical center.
Right. And I think that's really important. So the next hormone I want to talk about is progesterone. Can you give us the rundown on progesterone?
We use micronized progesterone. Progesterone itself is used in women with uteri, those who haven't had hysterectomies. So when we give estrogen, you can't give estrogen unopposed with a woman with a uterus. You have to have progesterone because it causes increase of the uterine tissue can overgrow if you don't have progesterone, because you need that flushing out of it. So we make sure that we give them micronized progesterone, which is less damaging to the patient than regular progesterone.
Gotcha. And now to the top one is estrogen. Everyone is concerned, or at least they should have somewhat of a concern about estrogen. Can you talk a little bit about estrogen?
Yes, estrogen. Estrogen is the hormone for bone for women. It's also for maintaining their lack of hot flashes in older women. We make sure that we use natural estrogen. And if you have a low estrogen, you're going to be at risk for osteoporosis. You're going to be at risk for the menopausal symptoms. So we also, because we're using the molecular identical, we actually can prevent the breast cancers from coming on. I mean, it's a bold statement to make. I don't want to be too bold in that, but since it is a natural biomolecular hormone, we are giving them youth at the same time. So, but in general, if we have a patient who has a family history of breast cancer or somewhat with that kind of history, we will not give them estrogen at all, because it's not something that we want to get involved with their families and things like that or some patients don't want to get any estrogen because of that risk, and we won't do that.
Right. And sometimes when you treat a patient, you're treating their family at the same time. I do recognize that.
Correct.
Happens more often than most people think. So I want to touch base on estrogen and osteoporosis, right? Because the typical presentation is, oh, you have osteoporosis now. The Fosamax was the big one, and they don't say, hey, let's go look at your estrogen levels. That doesn't seem to be a very common thing to look at when we're talking about osteoporosis.
Yeah, see, estrogen stimulates what's called the osteoblasts. Osteoblasts are those hormones that grow bone. If there's a lack of estrogen, there's a lack of osteoblasts, and too much osteoclasts. Clasts decrease the bone, and one develops osteoporosis without the optimal levels of estrogen.
Right, because I mean, when they see osteoporosis, like the medication, they start telling them take calcium, but you can eat all the calcium you want. That's never going to.
But you need estrogen for the calcium,
right.
Correct?
Right,
and you need vitamin D as well.
Right.
With the calcium.
Right. Most of the time when we talk about vitamin D, we always give them something like vitamin D and vitamin K together as well.
We give ADK with vitamin A, D, and K.
Right, and that's the thing. People don't realize that vitamin D itself is a hormone.
It is. It is a hormone.
Right. A lot of folks don't get that, and that reference range is a pretty large reference range between 30 and 100. But now it's interesting because we're getting pushback all the time by the insurance companies for this very, very simple test. So I think vitamin D is more. If somebody has to pay cash for vitamin D, I think it's like $18 to $30. It's really cheap. I think it's great information. Usually have great improvement when vitamin D is given, especially within the reference range. But we've had a few folks taking too much. We had to back them down. And again, that's where I think it's important to think about, how much vitamin D should they take. So here's a question: MK4, MK7 with vitamin K. That helps with bone density for women on estrogen blockers. Is that true? Do you know about that?
I do. I don't specifically know about MK.
I didn't know about that one as well. So the next question I have is, in our field, like we want to talk about, why don't our traditional conventional medical docs want to test for hormones? Some do, but a lot don't want. And they say, well, what I test for you today isn't going to look the same 2 weeks from now. So which one do you want me to treat from, right?
We're not trained to do it in traditional medical school. We're not trained to look at hormones. That's all there is to it. I discovered, only because of my interest in helping people who had problems that were testosterone related or any other related. So I looked into myself, but we're not trained about hormones or optimization or anything like that.
Gotcha. And my other question would go back to testosterone. When men are taking the TRT, what are you looking for, and how fast can they see results?
Like
the testosterone.
One has to be careful. TRT, that's synthetic, is not good for patients on a regular basis. And there's different ways to administer TRT. You can put creams on. You can do shots of testosterone on a weekly basis or biweekly basis. But we do it through a pellet therapy. And what our testosterone is molecularly identical to our human testosterone. And we go to the lower back area, upper buttocks area, and we put pellets into men and women that form basically a gland inside the subcutaneous area, and then capillaries form around it. Capillaries are basically blood vessels, form around that within 10 days to 2 weeks. And then it is based on cardiac output, how we exercise, whether we move, whether we don't move. While we're sleeping, the cardiac output is lower, so it doesn't cause any problems with increasing the testosterone. But when we're awake and alert and exercising, then we get the benefits of the higher levels of testosterone through these pellets. And that's how we do it.
Interesting. So in the 70s, my mom, she's long gone, she used to get these hormone pellets put into her back.
Wow.
Yeah. I mean, and it wasn't the size of a grain of rice either. But it was interesting because my father would say, "Oh, she's hormonal," and my mother would say, "He's hormonal." I think a lot of men don't realize that we go through hormonal changes as
Oh, absolutely,
you know.
absolutely.
So I think that's often overlooked, right? So it's couched as something
They
different.
call men who have overly hormones ADD. Poor
And,
thing.
right. And no, that's an excellent point, right? Because I think it's just couched and diagnosed differently when a man goes through these hormonal changes compared to a woman. So in staying with estrogen or going back to estrogen, one of the big studies that was out there was the Women's Health Initiative. And they just said, hey, whatever you do, stop taking estrogen. And this is the worst thing for you.
That's the worst thing they could have ever said.
Right. And this is what we find true now.
Without being too complicated, they wanted hormones to see who help. They wanted to use hormones to see what happens with heart disease, breast cancer, colorectal cancer, and osteoporosis. But the studies were used with women who are much older than the population that actually needs testosterone and estrogen. So so a lot of it was skewed, and these patients were going to have breast cancers or heart disease earlier in the study anyway, because they were a much older population, and they totally disregarded the fact that there was people with osteoporosis. Or what they did was they didn't critique the studies enough. The study just said hormones are bad, because they started the study back in 1991, and about 2004, because of increase in breast cancer, because the population was skewed, they said hormones are bad. And it totally destroyed the benefits that people, men and women, could get from testosterone because of a flawed study. It was a flawed study.
Yeah. Because the scream for the longest time was, oh my God, estrogen will cause breast cancer. And
But not
turns
natural.
turns
But not
out that's
natural.
not true. So can we
Correct.
talk about then, the bioidentical hormone replacement therapy versus the the synthetic? And, is there ever a situation where someone should have the synthetic, or is it always good to get the bioidentical?
I don't give synthetic, but the ACOG, which is the American College of Obstetricians and Gynecologists, they believe that the Women's Health Initiative is gospel. However, they still give hormones in the form of the synthetic form, and they're not doing patients any service by giving synthetic, because it can wind up giving problems with cholesterol, problems with breast cancer, problems with uterine problems with the synthetic. The molecular identical that we give from BioT will not give any of those problems at all.
Excellent, excellent. And when somebody gets on the BHRT, when is there the follow-up? Is the follow-up like 4 weeks afterwards? Do you blood work
Yes,
again? How do you work it?
we take blood work 4 weeks after to see if their testosterone level is good. We see if their estradiol level is good. We check their free T3 level, and we see if their cholesterol comes up or whatever. But we do that 4 weeks, and then we adjust if we have to. We'll give them a boost if they need a boost. If they feel that their symptoms, when they come in, I feel tired, I feel lack of libido, and then we give them the estrogen, and we give them the testosterone. And a woman will come in and say, I feel great, just leave it alone. And then for 3 months, they are feeling good. 3 to 4 months, they're feeling good. And then afterwards, because it's a gland that we're putting in there, it rises up into the bloodstream and goes for an optimal level for a certain period of time. Then it decreases over time because it's used by cardiac output, and then we just reboost you and come back up again.
Okay, so I want to wrap my head around it. So you're looking at somebody, they come in and they have low levels of not just estrogen, but low levels of progesterone. Of what you're giving them is like 2 different pellets, or in the same pellet?
No, it's all we give testosterone and estrogen in a female. So they're teeny little pellets. Testosterone at, say, 100 milligrams, with estrogen at 3 milligrams or 6 milligrams, a very, very teeny pill. Those two we give. In males, we give a little bit bigger pill, say a 200 milligram. We give them 10 times the amount of testosterone in a male than you would for female. And that raises their level of testosterone to the right level.
Gotcha.
And we use this by, what we do is, it's a simple process that takes probably 4 minutes, 5 minutes for women and men, where we numb up the area in the lower back, upper buttocks area. And we use a little trocar to open up an area. We insert the pellets in there, take the trocar back out, put a steri strip in there because there's no need for any sewing, any stitches. And within 3 or 4 days, you can get back, resume your activity, and the gland is set inside that area. And you start to feel the process after the 10 days to 2 weeks, and it feels wonderful.
And without any of the side effects?
No. Well, side effects for men might be that their sight is a little irritated for a couple of days. Sometimes, rarely, there's an infection, but that's we do a sterile procedure, and oftentimes it doesn't happen anymore from that. And women have no side effects at all. That they feel pretty good.
Gotcha. So who shouldn't get, bioidentical hormone replacement?
Like I said, any woman with a history of breast cancer, I will not give
and what about a male?
estrogen. Well, if there's a severely cardiac patient that has a congestive heart failure or something like that, I will call up their cardiologist to see if they have a problem with it. Most times they don't, because testosterone doesn't interfere with any medications.
Okay, so even if they have like a hypertrophic cardiomyopathy,
I'll call the cardiologist personally and say this, and I'll explain it. I'll send a white paper. I'll send all the information on all the studies that we have done, that BioT has done, that researchers have done on the benefits of testosterone and estrogen, and let them make their decisions. And most, 9 times out of 10, will say, yeah, that's pretty good. Let them do that.
Gotcha. Okay, so when they're on this hormone replacement therapy, are you okay with them taking vitamins and supplements? How do you feel nutrition plays a role in what they're doing as well?
Well, it's a whole body system. It's a whole program. We promote wellness as well as just testosterone and estrogen. So sure, we want them eating good nutrition. We want them eating fruits, vegetables, legumes, all the fish, etc. We want them to exercise on a regular basis. That's why we give them the energy to exercise. Yes, they can take any supplements that they feel they need for themselves. We do some supplements for the patients, ADK, like I said, we do that. And if they have cholesterol problems, we give them cholesterol medicines if they need it, whatever they need.
Okay. And is there insurance cover usually most of this? That's another frequently asked question I get.
With our patients, the consultation usually is covered by their insurance company. So that's covered by their insurance, and their laboratory is covered by the insurance. The actual procedure is not covered by the insurance. So it's a very reasonable way to help people.
Okay. And if someone's looking for prices, they can go on your website and stuff like that?
It'll be, the prices are on the website. That's correct.
Okay. Or just call the office, but
Call the office. Peggy will tell you.
Can you share with us a case study, something that really comes to mind, hey, this made a huge difference?
Yeah.
Although case studies are anecdotal, I find I get more out of listening to what another doc did for a patient than I did looking at a double-blind randomized controlled trial or a meta-analysis, to be honest with you.
Well, in my own case, back 11 years ago, I was run down and depressed, and I haven't been since I started that. But that's one case. Another one, a man came to me and said he wanted his wife because of her low libido. She is remarkably, he is thankful, and she's thankful that this is occurring. So we saved the marriage. Another one is started in her 40s. In the summertime, and she was on antidepressants for 20 years on antidepressants. She recently got the testosterone estrogen replacement, she's off all of her antidepressants.
Beautiful.
So these are remarkable things that happen.
That is remarkable. Again, I think hormone is often overlooked. I don't think they think about it. And most of the time patients come in with the question about hormones based on something they read, not what their doctor told them.
There's a lot of internet information, misinformation, et cetera, et cetera. So if they have a center they can rely on, we have 4 nurse practitioners and myself that do these therapies. There's a great resource from our office, Balance Found. It's in Floral Vale. It's less than 30 minutes away from your office. So they can get great information from us. They can weigh what they want to do, whether they want to do it or not want to do it. Come in, consultation will be covered by the insurance company. They can make their decisions. We have information for the people. We have books for them to read. We have articles for them to read, and they can talk. We give them numbers for patients to talk to patients and say, how did this do for you? And they'll say nay or yay, but of course, it's 90% yay for all this. 95% people say, I love it. Sometimes the first time they get the pellet, they may not feel as good as they think, but the second time they get it, say, oh, this is wonderful.
Okay. And Medicare covers at least the initial visit? Do you take Medicare?
Oh, absolutely. Yeah. If it's a Medicare pay, yeah, they cover the visit because we're on all the insurances. That's why we're a comprehensive medical facility. So we do take the insurances for that. It's not just you pay cash for everything. We don't do that. We make sure we take the insurance for that. And they use their lab work with their insurance company as well.
Right, which I'm sure is pretty easy to get.
Very expensive.
Yeah.
Well, the lab's taken care of by their insurance.
LabCorp Quest, straightforward.
Yes.
No crazy stuff. Okay, great. So when someone wants to get in touch with you, I'll put your website information up there. If you can share it with us now, though, as well.
Balancefound.com.
Okay, great. So we'll do that.
The phone number is 215-BALANCE, 215-225-2623.
Excellent. So I have 2 questions, and we went over these before. I want to pull this up on my phone and get this question direct. So again, this question is regarding cholesterol and atherosclerosis with very low T that Zocor pretty much crushed decades ago. Wants to try hormone therapy, but last time that person ended up with a clot. So the question is, taken together, the findings indicate that testosterone deficiency can increase the serum LDL cholesterol and total cholesterol levels by altering the expression of the PCSK9 and LDLR, and might increase the risk of atherosclerosis and cardiovascular disease. So that question, can somebody with this type of hypercholesteremia, maybe a familial hypercholesteremia, utilize the bioidentical hormone replacement therapy, the work that you do, and not be concerned about, the atherosclerosis?
Yes, absolutely, because the cases you're talking about are those that were using synthetic hormones. I know that for a fact. Synthetic hormones cause an increase in the LDL and the ratios, and you don't want that. But molecular identical do not do that.
Excellent. And the other question was, and again, a frequently asked question, hey, Dr. K, is there something I can do to eventually come off of my synthroid levothyroxine medication? And we talked about that a little bit.
Absolutely. If our balance of testosterone and estrogen is good, and then we give them supplement the 3T3 with the Armour Thyroid or the Nature Throid, we can get them off of their synthroid or levothyroxine, but they can also become euthyroid by feeling better anyway. See, thyroid varies. You're underactive, you're hypothyroid, you're overactive, hyperthyroid, hyper, and then you're euthyroid. We can get that balance and make them euthyroid and take them off of all thyroid medications.
And I know everyone is different, but what have you seen in practice? If this occurs over 2 months, 3 months, 4 months, where they can come off of meds?
That specifically, probably 5 or 6 months for the thyroid. Okay. Yeah.
That's fantastic. Absolutely fantastic. All right. We covered a ton tonight. That's really great. I really appreciate this. Is there anything else you would like to add?
No, I just want to say that patients have been very happy with us, and we have a great staff, very friendly staff. Peggy is the point person.
Yeah, Peggy's been great.
for our staff. Yes, and she introduced me to me, and it was a very, very nice thing that you can do for us. And anytime you need any help, we can help you with your patients if you would like. We're not salespeople, so I'm not going to make all a big promotion. We're a medical facility, and we help people on a regular basis, and we're very proud of what we're doing.
Excellent. So again, thank you very, very much for your time tonight. Hang out for 1 minute. Everybody, this will be up on YouTube as well, so you can watch the replay. We'll talk to everybody soon. Stay healthy.
Bye-bye.